So first off, can you just give us a bit of background about who you are and what crowd care is, what health tree is, that sort of thing?
So my name is Jenny Ahlstrom, and I'm a multiple myeloma patient. I was diagnosed in 2010, and it was kind of a younger diagnosis. I was 43 at the time. The average age is typically 69, so it was a little unusual. After I went through treatment, I just saw gaps that needed to be filled from a patient perspective. So that's why we created the foundation, and we started building programs to just fill those gaps. There were already good patient advocacy groups in place, but I just really felt like there were things that we wanted to do, and we had kind of a tech background. So I had worked for IBM before. My husband's a entrepreneur and investor, so we treated my disease pretty much like a startup. Like how would you find a cure for a rare cancer if you had to start from scratch? There's a lot of development being done in myeloma, so you don't have to start from scratch in myeloma. But as we built these tools, we built Health Tree is kind of a flagship product that we built, and it does two things at the same time. It helps patients navigate their disease while they're going through their journey. So for example, after patients, they can track their data, they can track their labs, their genetics, prior lines of therapy. They can use it to find treatment options they can consider that are personally relevant based on expert opinion, as if they were being seen by a specialist. They can find clinical trials that they could join that are personally relevant. So instead of going to clinicaltrials.gov and going through several hundred studies, it just shows you the list that you can qualify for based on eligibility criteria. You can find your twin, like your genetic twin for your type of cancer, and then you can chat anonymously without the other people that look like you. You can see, you can join, and then the second thing it does is it accelerates research. So we can, patients can answer survey questions and join studies inside the platform. It's IRB approved, and then we work with different, like we're collaborating with like Memorial Sloan Kettering and Roswell Park and other facilities to run actual studies inside the platform. That's kind of what that does.
Great. So looking at telehealth now, throughout the COVID-19 pandemic, what have telehealth visits specifically offered for patients with cancer?
So we did a survey, we did a study inside the platform, like I was saying. We were able to recruit 1,100 patients within 4 weeks, which I think is pretty remarkable and different for COVID. So whether they had tested positive or not, we just wanted to know how myeloma patients were being affected by COVID. And we asked that question. We said, how many of you did telemedicine prior to this? And there was 10%. And then how many of you are doing it now? This is like in the April-May timeframe, so kind of in the thick of when everybody was completely quarantined and everything. It was 60%. So for multiple myeloma, it's a cancer in your plasma, so you're looking at a lot of lab or lab type work, clinical stuff, and you're not really doing a physical assessment of the patient necessarily to make a determination as to whether you need to retreat or if the patient's relapsing. So a lot of the myeloma experts really said, we're surprised at how much we can do with telehealth. And I think there are concerns that people go maybe too far and they say, okay, we'll go all telehealth, but you really need a balance. You need to do what's right for the patient. So the patient needs to be able to decide, well, do I feel okay? I'm just doing a quick checkup. All my visits up at Huntsman Cancer Institute have been telehealth over the last 6 months, and they've been just fine. I've gone up there for labs, but and then I've been able to get a second opinion consult with other doctors out of state, and I just don't want to see that go away because myeloma patients especially, and I think other patients with other types of cancers, especially for those for which you need a specialist. So like in multiple myeloma, 80% of patients are being seen in a general oncology setting, but it's probably one of the most complex cancers to try to treat. You have combination therapies that need to be combined. You're constantly making a decision because you keep relapsing time and time again. And it's not like a remission where, you're 5 years out and you're clear. It's not like that with myeloma. So you're trying to evaluate your options, and patients by years. So University of North Carolina did a myeloma, sorry. I'm stumbling over my words. The University of North Carolina said that if you see a myeloma specialist treats you, you can live 39% longer. And the Mayo Clinic did another study that showed you could live at least 2 years longer because you are being seen by specialists. So the expertise matters. And who wants to put like a 75-year-old on a plane to go get a second opinion right now? It just doesn't make sense. So I think the waivers opened everything up. And in talking to some of the doctors, I interviewed a doctor at Mount Sinai, kind of in the heart of all the New York chaos. And he said he's watching facilities or payers or states just lock the waivers back down. And it doesn't really make sense for patients still in the middle of a pandemic. And this was kind of like I mean, I fly and I go get a second opinion from one of these experts. So why can't I? It doesn't make sense. Why can't I talk to them over a video conference and do the same thing? So the restrictions, the state restrictions just never made sense in the first place to me. And especially don't make sense in a pandemic.
So just to kind of elaborate on that, can you explain what the loss of telehealth waivers could potentially mean for patients with cancer? I know that you touched on this a bit, but moving forward, if this continues, what could this mean for patients with cancer?
So it means they don't get specialty advice or an expert's advice is what it means. They're less likely. There are a lot of patients. I mean, 20% of patients are being seen by an expert. You don't have to get treated by the expert. You can go home and get treated and get all your infusions and all that. But when you're making a key life-saving decision, you really need the help of an expert. I mean, I've been doing this advocacy work for over 8 years. And I'm trying to make a decision about my own care. And I need because it's free. So people say, if you ask their opinion, you'll get 5 different answers. And that's really true. So I'm kind of getting this rounded view of, okay, I could consider this, or if somebody has more of an immunotherapy expertise, they kind of might lean more heavily, or if somebody has transplant experience, they might lean more heavily there. And then I need to make a decision. So I need as much information as possible to be able to make that decision. And it's a life and death decision for me. Like when you're starting out for care, your first remission is your longest and your most durable. So if you're not getting an expert opinion and you're just going to somebody who's treating 20 other cancers and just can't, there's no possible way they can stay up to speed on all the nuanced care that needs to happen in myeloma, you're just not going to do as well. So it's sad. Patients need to be able to consult with experts on their care. So we've tried to enable them with automated tools so they can go have an intelligent conversation with their doctor. But I don't think there's anything that's ever going to replace that even virtual face-to-face conversation with a doctor. Like, what should I do? What should I consider? It's just critical for patients.
So as we move into what appears to be another surge in cases of COVID-19, how can patients with cancer ensure that they're receiving the safest care?
I don't know. I mean, how do you? I tried to get a telemedicine visit in Arizona. I was able to get one. I tried to get one in Texas because my former doctor was at MD Anderson and I was not able to get one. And so like, why? It doesn't make sense. I think patients might need to speak a little louder that this is necessary. I think there needs to be, I've been talking on several panels about telehealth and these different waivers. I think there's some concern that they won't get paid for as if it were a normal visit. So getting that out of the way and removing that barrier, they can be equally effective to a live visit if it's appropriate. If I'm having a lot of pain in a certain area though, I probably need to go in and see my doctor and telehealth's not going to cut it. But If not, and we're just reviewing labs, then, you know, I can do that over a video call and totally adequately. We even in HealthTree, we even before the pandemic hit, we thought health we had taught thought sorry even we really thought health was important. So our software team, we do a lot of in-house software develop and build tools for patients. Kind of unique in that way. I don't think a lot of patient advocacy groups think about using software in that way. But so we're building our own telehealth platform to enable that. And hopefully these waivers can stay, and especially during a pandemic. I mean, it just doesn't make sense that anybody would pull them back, especially during a surge. I don't get it.
So I know that you just talked about what you all are doing, but are there any other ways that patients, or that you know of at least, that patients can advocate for themselves and advocate for telehealth coverage?
Well, I asked that question. It's a really good question. I asked that question on a panel that I was doing with one of the pharmaceutical companies. And I asked kind of my peers who were across a lot of different diseases, and their suggestion was just do a lot more talking, you know, to like share that message and start having that conversation with legislators as well, because there are certain payer issues that are out there that aren't just that, you know, require regulatory changes, and each state is doing things its own way.
So that's all I have for you. Is there anything that I didn't ask that you think is worth mentioning in this space?
um, I don't know. I just think telehealth needs to continue. It's a really useful tool, and it allows flexibility for patients. So whatever the patient needs at that time, they can do, whether they can go somewhere or not. It's not exciting, even for me as a younger patient, to go to the clinic where I feel like I'm exposing myself. But for older patients who will have other comorbidities, diabetes and heart disease and renal issues and all those things that are really high risk for COVID, it doesn't make sense to send them to the clinic, or especially to put them on a plane to try to go get an opinion.
Absolutely. Well, thank you so much for taking the time to speak with me. I really do appreciate it.
Sure.